My name is Arvind. The topic of my presentation is prostate cancer hormonal mass. Is the outline okay? According to NCCN, orbital confined prostate cancer is that is inside the prostate and does not spread to other parts of the body. It is also called localized prostate cancer or is T1 or T2 prostate cancer. It is the epidemiology of prostate cancer. About 1,7,500 new cases of prostate cancer annually in the body. It accounts for 20% of new cancer cases in men. In Pakistan, the prevalence rate is 98.6% for prostate cancer. Count for it is the epidemiology. About 1,7,500 new cases of prostate cancer annually in 2019. Accounting for 20% of new cancer cases in men. In Pakistan, the prevalence rate is 98.6% for prostate cancer. Counts for second most prevalent cancer in men after lip or oral cancer. If we see in the each standardized incidence and mortality rate of top 10 cancers, the incidence and mortality of prostate is second highest after lip and oral. The incidence and mortality of prostate cancer is high in developing countries as compared to developed countries. It is also highest among lack of it. Prostate. The prostate gland located below the neck and above the urological diaphragm. It is first by the respiratory and most proximal part of the uterus. It is partly granular and partly muscular gland. It is approximately 4 into 3 to 2 centimeters in size. The pose of prostate. Prostate consists of two capsules, two and false capsules. Two capsules are thin strong layer of connective tissue at the periphery of the brain, while the false capsule lies outside the two capsules. It is the condensation of pelvic fluid. Between these two capsules lies the prostatic plexus of the brain. As the previous shows, falls and two capsules and plexus of vein between them. It also shows the lobes of prostate and anterior lobe, medial lobe, and posterior lobe. Zones of the prostate. Prostate consists of three zones: peripheral zone, central zone, and transitional zone. The peripheral zone is almost head of region of carcinoma prostate. The following are the etiologies of prostate cancer, which are family history, genetics, metabolic disorders like diabetes, obesity, high testosterone level. Studies show that if two or more relatives who have early onset of prostate cancer, the person with prostate cancer high risk of prostate cancer, metabolic syndrome like diabetes. It is observed uncontrolled diabetes also increases the risk of prostate cancer. patient on antidiabetic often that follow the user was found to be at huge risk of prostate cancer diagnosis as compared with never. Just to increase the risk of prostate cancer, it is also observed that the patients who are on statin therapy, the risk of prostate cancer also reduced in that case. Testosterone promotes prostate cancer development. Studies show the men with very low concentration of testosterone have a below average risk of prostate chromosomal abnormalities. Genetic mutations also is often involved in the pathology of prostate cancer, like it can include for helping describing prostate cancer. The addition of deletion of some specific nucleotide sequence are also associated with progression of prostate cancer. Specifically to the loss of AT2.2 and gain at level 2 13.1 of the prostate cancer. Family history of BRCA1 and BRCA2 mutation often increases the risk of prostate cancer as well as the risk factors. It includes environmental factors, social factors, diet, dirty factors, family history of prostate cancer, rescue, hormone changes, high testosterone, advanced age, racial factors, ethnicity, ethno, and prostatic insufficiency. Here is a type of urology of prostate. As the figure shows that different stages of prostate cancer from normal prostate to prostatic to the prostatic cancer. In normal prostate, there is uniformity in the epithelial cell of prostate and and normal architecture and normal architecture. Proliferative inflammatory response. Here we can see the excessive proliferation of the epithelial cells and infiltration of inflammatory cells. There is also the atrophy of epithelial cells. Prostatic is the epithelial cells. Here all the cells lost their uniformity and cells are of different size. Mitotic figures are seen prostate cancer. Here in prostate cancer, there is uncontrolled proliferation of immature cells are present. According to ICS, the urinary incontinence is period of any involuntary loss of urine. Adenocarcinoma accounts for 95% of prostate cancer. It develops in SNI of prostate cancer. There is the common type of prostate carcinoma account for 5% of prostate cancer. It includes small cell carcinoma, uterus carcinoma, constant cell carcinoma, basal cell carcinoma, neuroendocrine cancer, and squamous cell carcinoma. As in the shown in the figure, the SNF adenocarcinoma occupy a major portion of pie chart. Clinical findings. The patient with prostate cancer presents with obstructive or irritating voiding, bacteria, hemophilia, dysphagia, urinary retention. Patient in early stages may be asymptomatic. Clinical examination. It may be through rectal rectal examination. If the rectal examination, there is then we go for further evaluation, like prostate precipitation level, ERUS, and rectal level. Tumor markers. Prostate specific antigen level. It is prostate antigen level produce benign and malignant prostate tissue. It is a serine for period in blue calcium and prostate specific antigen group both as diagnostic tool as well as its standing for non-prostate. Normal PSA level are less than 4 nanogram per the PSA level between 4 to 10, around for 20 to 30% is risk of cancer, and more than 10 nanogram per ml around for up to 70% risk of cancer.
I want to add something here,
Prostate cancer antigen.
Ali. Just a moment.
Yes, sir.
I want to add
Yes, sir.
something here. Recently, um, this whole um, normal range of PSA has been redefined, and now it is not between 4 and 10, it is between 2.5 to 10, or maybe 15. So the normal range is from 0 to 2.5 at the age of 50 years. So whenever we take any range of normality, we always take into consideration something called age. If somebody is a male person having an age of 45 years and below, there is another level of PSA, and that is less than 2.5. But if the person attains an age of 50 to 55 and then beyond, this range of PSA is normality is changed. So for all purposes, if you have got a patient who is 50 years plus, the normal range should be below 2.5 nanogram per ml of PSA. The gray area lies between 2.5 to 15 nanogram per ml. Now, this is the area within which, if the person exists, then you have to do certain other things. For instance, you take into consideration called something called PSA density. You take into consideration something called free and total PSA ratio. So this is the way to go about all these things. Um, the older range, which is actually being presented here in your slide, 0 to 4 is something which is not regarded as as of a normal range now these days. So we have changed a little in recent times. You can continue, please.
Yes. It is the overexpression in majority of prostate cancer with a median 66-fold up resolution as compared with the adjacent non. PCC predicts the presence of cancer in biopsy, setting with an accuracy of 7.4, 74.6. Diagnosis and evaluation. First of all, prostate biopsy. Prostate biopsy considered in men with elevated serum prostate specific levels, abnormality, or miscontrol. Prostate biopsy performed under trust guidance. Biopsies are taken throughout the cervical zone. Study shows that literally the rapid biopsy of cervical zone increases the detection rate up to 20%. Rating and staging.
A little bit about
Tuesday,
prostate biopsy. Ali, just one
yes,
moment. If you go back to the previous slide,
yes, sir.
now no, prostate biopsy is not only taken through a transrectal route, but it can also be taken through a
Yes,
transperineal route. It can also be taken through a transurethral route. Now, whenever the prostate biopsy is taken, what is more important is the guidance. Now, the guidance can be through transrectal probe inside the rectum. That is the meaning of transrectal ultrasound. That is true, TRUS. But the needle can also go through the rectum, or the needle can go through the perineum. Now, these are the two things which can be done under the guidance of a transrectal probe. If you want to do a biopsy which is through the transurethral region, then it is under the guidance of the cystoscope. You are seeing it, and then you are taking the chips of prostate for biopsy. So in that way, we have got three different kinds of biopsies through two different routes.
yes, sir. If a primary tumor, TX cannot be, tumor cannot be excised. T0, no evidence of primary tumor. TIS, carcinoma in situ. T1A, less than 5% of in receptor for benign disease as cancer in normal DL. T1B, more than 5% of in receptor for benign disease as cancer in normal DL. T1C, detected from elevated PSA around normal DL and imaging. T2A, tumor capable by DL or visible by imaging involving less than half of one lobe of prostate, while in T2B, it involves more than half of one lobe. In T2C, tumor capable by DL or visible by imaging involving both lobes of prostate. T3 and T4 are not associated with localized prostate. It was the involvement of the regional network and M for different methods. These are also not associated with localized prostate cancer. If the stage 1 and stage 2, the prostate cancer is limited to prostate, while in stage 3 it's involving the semi-rectal, cervical, and neck of bladder, while in stage 4 it's involving somebody as well as node. Gleason score or Gleason sign. Gleason grade ranges from grade 1 to grade 5. Gleason score thus ranges from 2 to 10. Gleason score of 2 to 4 corresponds to the differentiated tumor, while 5 to 7 corresponds to moderately differentiated tumor, and 8 to 10 score indicates the fully differentiated tumor.
Right. Just one point here. These scores, Gleason score 2 to 4, 5 to 7, 8 to 10. This is known as Gleason grade grouping, GGG, right? And this has got its
Yes,
own practical implication whenever you do some therapeutic workup. So at this moment, for all of you to understand is we do a Gleason grading and we do Gleason scoring. How we do it, that is a separate topic. But whenever we have done the Gleason grading, then these grades are actually grouped into three different groups. And these are the three groups which you are seeing. So it's the score and the grade and the groups. So these are the things.
recent pattern. These are the five grades of releasing grade 1 to grade 5. Grade 1 and grade 2 correspond to very different tumors. Grade 3 moderate tumors, and grade 4 to 5 indicates four different tumors. In grade 1, the set of small and uniform gland. In grade 2, more probability land. In grade 3, there is infiltration of fluid infiltration of fluid and more spaces between glands. In grade 4, irregular meshing of glands. While in grade 5, only occasional gland formation.
If anybody wants to raise a question, please raise your hand so that we can involve all of you. Yes, please proceed.
Reason for and International Society of Urological Pathology. Reason for of 226. Reason for of 226 indicate ISUT grade 1. Reason for 2 plus 4 indicate grade 2. Reason for of 4 plus 3 indicate grade 3. Reason for 8 indicate grade 4. Reason for 9 and 10 indicate ISUT grade of 5. European Association of Urology is good for biochemical treatment of localized and locally advanced prostate cancer.
Just a minute, Ali. I
Yes,
want to ask everybody, they are on board or they are not. Are you listening to me and Ali or not?
yes, sir.
So,
Yes, sir.
right.
Yes,
So,
sir. Yes, sir. Yes, sir. Yes, sir.
okay. So, do you understand what Ali is saying about this Gleason score and grade?
No, sir, we are still not that much on the staging or grading.
Right.
So we will be इसको ज़्यादा पढ़ेंगे तो फिर हमें ज़्यादा समझ आएगी.
Right. So I just try to make you understand because I can't just draw something and show it to you because I don't have that kind of platform here. But I assure you, or just imagine that the prostate is a pear-shaped structure. It has got a broad base and a narrow apex, right? Whenever you do biopsy, the biopsy is done in a fashion that it is symmetrically on the two sides of the midline. For instance, biopsy 1 and 2 is at the apex on the two sides of the midline. Biopsy 3 and 4 is in the middle of the prostate on the two sides of the midline. And biopsy 5 and 6 are at the apex. So these are 6 biopsies. Now, 7 and 8 are on the periphery of the prostate. If you have got a pear-shaped structure, then it is at the periphery and at the midline. At the midline, but at the periphery. So these are 7 and 8. 9 and 10 are very close to 7 o'clock and 5 o'clock positions. 7 o'clock is on your left hand, 5 o'clock is on your right hand, right? These are the 2 points where the actual neurovascular bundle is either exiting or entering the prostate. So these are 10 biopsies. Now 11 and 12 are those points which you think randomly that these are the points on your ultrasound picture which looks like abnormal. Abnormal means they are not isoechoic. They might be hyperechoic or hypoechoic. Because when you do ultrasound, it is always the echogenicity or the reflection of the ultrasonic waves which you gather on the screen as something called iso, hypo, or hyper, right? Now, in that way, you have got 12 different biopsies. Whenever you have got 12 different needle core biopsies, these biopsies are sectioned and then seen separately below the microscope. Every biopsy is graded according to the 5 grades that Ali has shown. to us. Now, suppose if biopsy number one is of the grade, I think three. Biopsy number two is 4. Biopsy number 5 is maybe 3. So you calculate each biopsy according to the grade, and then on a paper you always have 12 biopsies having maybe similar grades or different grades. Now the most common grade is known as the primary grade, right? So maybe the most common is in 3 4 samples, it is like 4, grade 4. So this is the primary grade. The secondary grade is the next common grade. Maybe it is 5. So the total score would be 4 plus 5 is equal to 9. Whenever you come to me, when the things are normal, then I'll show you again. It will be very easy to understand,
Yes,
right?
yes. And there's a whiteboard, you can provide a whiteboard next to that now.
Yes, sir. Just repeat your question.
Means I think there's a whiteboard, so you can provide there.
Yes, there is a whiteboard, but I can't just show you the whiteboard.
We'll
Maybe,
do that. Okay.
just I can just draw a figure on my paper.
You can share whiteboard.
ये हो सकता है. Next time सोचते हैं इसको किस तरह करेंगे. ठीक है. चलें. Proceed, please.
So, yes, sir. In the technique. First of all,
Shesha wants to say something.
Yes, sir.
You want to say something?
Sir, in the previous slide,
Yes.
in which Ali had written the grade of 7, and then there was 4 plus 3 and 3 plus 4. So this 4 and 3 were the primary grades and the secondary grades.
Yes. You see, the first figure in every sum is the primary grade. And the primary grade, as I've said earlier on, is the most common grade in 12 samples or 6 samples or 8 samples, depending what is your biopsy protocol. Sometimes it is sextant, which means that there are 6 different samples. Sometimes it is octant, which means there are 8 different samples. Sometimes it is 12 core biopsy. So whatever the number of biopsies, these biopsies are always in even numbers. They are not in odd numbers. Whatever you do on right side of the prostate, you always do symmetrically on the left side of the prostate. And you grade all of them. The first common grade, for instance, in the second instance, it is 7, which is 3 plus 4. This means that the grade 3 is the primary, grade 4 is the secondary grade. Now, it is different from 4 plus 3. Both are 7, but here the primary is 4, which is more grave as compared to the above 3 plus 4. So whenever the first grade is changed, the actual primary grade is changed, and then the severity of the disease or the gravity of situation is also changed.
The transrectal ultrasound. It guides the prostate biopsies and other prostates directly to the lens. Endorectal MRI. The accuracy of endorectal MRI varies from 61 to 92%. X-ray imaging includes CT scan, MRI, bone scans. Bone scans are done to rule out any prostate. Antibody imaging. It is FDA approved for initial staging and treatment. Chapter 4. Chapter is cancer of the prostate.
No, just a word about the investigation that you have been describing. You see, prostate is something which is very common, prostatic cancer, and in urology, it might be the first one in the Western world, but all over if you take into consideration all the neoplasia, then all over the world, prostate comes at number 2. Number 1 is bronchogenic carcinoma. So if you just imagine that this prostate cancer is the #1 cancer in urology all over the world, then they have put in a lot of money into it. Money in the sense that the technology to diagnose prostate cancer early has been much investigated, and a lot of money has been put in the research. So what we have got these days is known as multi-parametric MRI. Now it might be biparametric or multi-parametric, and what are those parameters we'll see later on when we discuss this topic in more detail. But the thing is, whenever you have got a person who comes to you in the clinic and you have done your physical examination, that is DRE, and there is a suspicion that the person has got a malignant prostate, which is a bony hard prostate on palpation, then what you do? You want to have an estimation of PSA. Now, PSA cannot be done at this point because DRE has been done, so you wait for a week or so. You do the PSA. If the PSA is abnormal, which is, as I've said earlier on, greater than 2.5 nanogram per ml, then you want to have biopsy. Now, there are two ways from this point in which you can take your patient. One is you can do biopsy straight away. The other more appropriate way is to do multi-parametric MRI first and then biopsy later. The reason being, if you have got an MRI picture in front of you, the abnormal signal in the prostate in MRI picture will always guide you if you want to do prostate biopsy yourself, or it will guide the radiologist to do a targeted biopsy, which is an abnormal signal on the MRI film. Now, this is known as fusion biopsy. If you fuse the image of the MRI with the ultrasound probe, which is guiding the needle, and the needle is going towards the prostate to take the biopsy. So when you merge these two pictures, they can be merged cognitively, which means they can be merged with your own perception and imagination, or it can be done robotically, which means that you interface, you just combine both the interfaces together. You combine the MRI picture and you combine the ultrasound machine picture through a software, and then the needle is guided by a robotic arm. So that is known as targeted fusion biopsy. That will increase the yield of your hitting the target 100% rather than going around the prostate looking for a positive biopsy. Maybe you get one, maybe you don't. So this is the way the world is moving, which is targeted biopsy. But for that, we need an MRI that is multiparametric, and we don't have it. The next point I want to just add here is the concept of and the usability of PET scan again. As we have discussed yesterday also, PET scan is not something which is primarily used for the diagnosis of any cancer. It is used as a prognostic tool. It is used whenever some treatment has been given primarily, and then you want to see whether there is any residual tumor present, or there is a recurrence which is there, or there is a doubt that is it a recurrence or is it something which is inflammatory in nature. So this is the way we all should move, the way the world is moving and the way we are moving. We don't have multi-parametric MRI, but we have PET scan, but the PET scan should be used judiciously and with some science behind it. Yes, please proceed.
Data score. It reads the outcome of the patient after treatment of prostate cancer. Data score from 0 to 2 indicate relatively low difficulties. Score from 3 to 5 indicate intermediate difficulties, or and score from 6 to 10 indicate high difficulties. normal management of the patient. It includes general nutrition, treating captive surveillance, radical protection. It includes open and laparoscopic protection. Open protection is done by two proteins from retroclusive and perineal approach. As soon as being this allows the safe delivery of 500 to 7,000 centimeters of radiation to the prostate. Next, brachytherapy. It is in this technique where a radioactive shield under surgery. Essentially, we look for a treatment of localized prostate cancer. Here is a figure shows techniques of surgery. This includes needle, ultrasound probe, and ultrasound. In surgery, freezing of prostate is carried out by using multi-scope style device. The temperature at the end of asphalt is 0 degrees Celsius to minus 2 degrees Celsius, while the actual cell destruction required minus 25 degrees Celsius to minus 2 degrees Celsius. Exploratory treatment destruction occurs up to 2 millimeters inside the alveolar edge and cannot be measured by ultrasound imaging. Focal therapy. It is focal therapy is target oriented therapy. It targets only a tumor while staying in the normal for their on.
Right. You go back to the slide regarding radiotherapy. Yes. Do you want to say something? Somebody has raised their hand.
Sir,
Ji.
Usability is more than 2.5 है according to the new verdict format.
Ji.
तो अगर तो हम patient is asymptomatic, otherwise मतलब उसको कोई मसला नहीं है, लेकिन prostate 2.5 है तो should we stay here और कि हम देखेंगे whether he has developed cancer or just we should wait and wait to watch for the
Right.
symptoms to develop or something.
You see, there are two ways of answering this question. One is uh, the protocol. The protocol of managing your patient in any hospital, in any setup, um, that varies from place to place. For instance, you might be working in Pakistan, you might be working in any other country. So whatever the facilities that are available, you have to make use of them for the benefit of your patient. The kind of culture that we have, and meaning to say the kind of patient culture that we have is uh, in SIUT, what any person who has got lower urinary tract symptoms comes to us in prostate clinic. So whenever a person comes to us in prostate clinic, he has got some problem with urine, either irritative or obstructive in nature. We always try to assess if the person is not catheterized, what is the actual maximum flow rate of that person. We do DRE, we assess the prostate volume, but we also do the PSA. Why we want to do PSA? Because PSA in our country, Pakistan, is not being used as a screening tool. But the ideal situation is every person who is 45 years plus should have a PSA, because this is a disease which might start somewhere without causing any lower urinary tract symptom, and it is something which is devastating in nature and velocity. So if you are a urologist and you are obsessed with prostate cancer and you think that it is something which is common in your population, in your country, then you might be obsessed with doing PSA as something which is a screening tool. So this is my understanding. Whenever a person comes to me, I always give that person benefit of doubt. I always want to assess PSA, and this newer addition of lowering down from 4 to 2.5 has given me an insight, in terms of managing my patient. If my patient has got any PSA which is less than 4 but greater than 2.5, meaning to say between 2.5 and 4, I would give him the benefit of doubt by doing a biopsy. If the person has got low infrared symptoms and something um, which will emphasize upon doing something called biopsy. Now, a biopsy is a thing which has to have some consent from the patient. So this is a two-way communication between the patient who wants to do something and the doctor who wants to do in favor of the patient. You see, many of the patients will ask you to prescribe some medication and don't do biopsy. So what you do? You prescribe medication and see after a little bit of time. For instance, you do another level of PSA after antibiotic therapy of a week or so. And if that repeat PSA remains high means greater than 2.5, then this is an indication for biopsy. Now, in that way, you will be able to increase the pool of maybe biopsy, but also increase the pool of positive biopsies, which we are not having at present in Pakistan. So, this is something which has to be discussed amongst ourselves, discussed amongst our colleagues in other centers also, because there is no national strategy of dealing with prostate cancer, for instance. So in Pakistan, nothing is in discipline. Everything is in flux, is changing. Uh, if you want to take a leading role, if you want to assume that you are a leader, then you must strategize yourself. This is my understanding of the whole subject. So if I am there in prostate clinic, I always take into consideration all these points, because again, this is my responsibility to deal my patients the best way possible. There is no money involved, at least in SIUT, so we can do it. Yes, Ali, if you are on, then
Yes, sir.
start again.
Here the figure shows the application of different diagnostics at different level range of treatment. Every year, food drug for prostate cancer, family for and microbiome each year. Now, our plan it includes schedule and frequency. First follow we begin about 6 weeks after the 1 year, in 1 year, there will be 3 to 4 visits after 4 months. From 2 to 5 years, every 6 months, and after 5 years, it will be annually. Examination to history, examination, lot test, and using study. There should be complete history examination with annual yearly. The body test includes PSA level after typical month for 5 years and then annually. Imaging study based on clinical indications. These are the benefits of those
Right. So thank you very much. Because of, I think, internet connection, there are a lot of um, intervals. Otherwise, the presentation was concise and it covers the whole topic. There are certain points which always needed to be discussed and explained in greater details. uh, that can be said for any presentation, and for this presentation also, it can be done again in a different way, and we'll do it after maybe the first round, the second round, we'll improve upon our presentations. So there is nothing to shy about. There is nothing to be discouraged about. I think Ali has done a good job. He can improve. We can always improve our skills, and nobody has been born with all these things. So we all have to learn it one day or the other. So the forum is open for any point, any clarification needed, or any suggestions. Just raise your hand, and then we'll ask questions. Noman, are you there or not? Because for the past, I think this is the second day I'm not hearing from you anything.
Now I just have a single question in my mind regarding trying to do the urine condition sensitivity and or prostatic smear to rule out or differentiate that the PSA is raised due to infection or due to the any neoplastic, the neoplasia, humorous procedure. But your last answer to Dr. Lakhov regarding the UTI case and the range of 2.5 PSA.
Yes, you see, this is a burning topic. This is a topic which is again debatable, and this point, I'm sure, I think you all were there in our CRC meeting where this point of 2.5 was discussed, and I was I was referring at that point also with the reference of the latest guidelines. Uh, but still, there is a reservation in the mind of pathologists who are running the show, actually, because they are the persons who will be dealing with these samples for PSA. For instance, our pathologist is not in agreement with this notion that it should be brought down from 4 to 2.5, the normal range. There are many, again, reservations in their minds also. Uh, for practical purposes, what the problem we face is in our society, in our culture, in Pakistan is number one cancer for us is bladder cancer. Number two cancer for us is kidney cancer. Prostate comes at the third place. Now, this is totally in contrast with the Western world. There, prostate cancer is the number one cancer. Number two cancer, maybe the bladder cancer, or number three cancer is kidney cancer. So there's a slight shift in places of number one and number two. Uh, why this is happening? Maybe we are phenotypically different. Maybe there is a genotype which is different in the population in Asia as compared to what is there in Europe. But some of our colleagues do not believe in this racial differentiation of prostatic cancer. What they believe is in India and Pakistan there are many cases which are there in population, and since we do not do PSA as a screening tool, we are not picking up those cases, those early cases which can be again dealt by radical prostatectomy, for instance. So we have got less and less number of radical prostatectomies in our operating list as compared to kidney cancer and bladder cancer. That's a true reflection of people who come to us in our clinics. We don't, since we don't go to the patients do come to us with problems. So we are not having a complete, clear picture of the disease spectrum. If we want to bridge that gap of knowledge and information, there is a way of doing it, and the way is to my understanding, the way is to keep it down to a level where we can do biopsies more and more so that we can hit more and more positives. If we do less biopsy, we'll be hitting less positive biopsies. If we do more biopsies, yes, we'll be having more negative biopsies, but we'll again proportionately have more patients with positive biopsies. So it is, I think, prudent to think that a person in the earlier stages of prostate cancer, if picked up, can be saved from a lot of comorbidities. That person can have eradication of the disease right at that point by doing radical prostatectomy. But if it is out of the prostatic capsule, it is not organ confined, it is locally invasive, maybe to the regional lymph nodes. If it hasn't gone on to the axial skeleton, again, the condition is not for radical prostatectomy per se. So you are actually minimizing your patients who can benefit from radical prostatectomy. If you do biopsies early, if you do pick up patients in early stage, you have got a very high rate of eradicating the disease at the very point of origin. So that's my understanding of the whole subject.
Exactly. More vaccine and more testing we get more drugs and we will scrutinize the more population and more our patients.
Yeah. And to the benefit of all our friends who are listening to us, the cancer work and the oncological work on part of a surgeon is always something which goes with obsession. If you want to dig out something, you can dig it out. If you don't want to dig out something, again, the negative aspect is always there. So if you want to have something which is not clear, you can make it clear by changing your course, changing your pattern of investigation. So if somebody says that I have got a lot of kidney cancer, how can I save nephrons? I If I don't do any partial nephrectomies, I will not be able to save the nephrons. If I do a lot of radical nephrectomies without considering the fact that some of them can be saved by doing partial nephrectomies, the nephron cannot be saved. So there is always a question which is posed by some of our colleagues. We should always take credence of those questions rather than reacting on them. And maybe there is a positive sense in all those criticisms that have been made.
But it was a wonderful presentation.
Yes, no doubt. Anybody who wants to say anything?
There's a question in the chat from an unintroduced student
Yeah, yeah,
in our class.
no problem. You want to say something, Shersha?
Yes, sir. I'm saying there's a question in the chat from an unintroduced student of our class session. Maybe they want to ask about the recurrence of prostate cancer.
Yeah, yeah. So, what that question is? This is thank you, Dr. Ali, and thank you, Team SIUT. I want to ask about the recurrence of prostate cancer. This is Namra, Komal Namra. I don't know how come she gets into it, into the group. Komal, if you are there, you can introduce yourself so that we know whom we are speaking to.
Yes, Assalamualaikum sir. My name is Dr. Namra and I am joining your class from Islamabad.
Right.
Volunteering. So it was a good presentation. Sorry, it was
No
not
problem.
found first, and I joined you in the middle of the session.
Right. So you want to ask about the incidence or the
Yes, sir.
prevalence?
Actually, I just want to know about if the patient is having his radical prostatectomy at the early stages, then how much there are the chances of recurrence of this CA?
You see, this is a very interesting, again, paradigm. Since in Pakistan, we don't have a lot of patients who are through the process of radical prostatectomies, we don't see patients with the biochemical recurrence. Now, that is one aspect of the whole topic of prostate cancer. which you will not see once if you do not do any radical prostatectomies, because if the PSA goes down to zero level, 0.000, 3 decimal places, then this is a radical prostatectomy which has been done um, because of good selection of case and because of a good staging of the process. Now, by staging, I mean that the cancer is organ confined and there are no lymph nodes affected by the disease. So if you have done lymphadenectomy and radical prostatectomy, the PSA should go down to 0.000. Now, if you follow these patients, there will always be a flicker, a rise in PSA. If it is at the third decimal place, it is of no value, but you have to do repeated PSAs maybe every 3 months. Once it gets into the second decimal place, meaning to say 0.02 for instance, or 0.03, then the radar should have a signal. Radar means that you should be alert. You should be alert and then you manage your patient accordingly. By management, I mean that you restage your patient at this point whenever there is a second decimal place increment in PSA from the nadir value. What you do is you do an MRI scan. If MRI scan gives you some clue, you can go on to have radiation therapy. If MRI doesn't give you any clue and PSA remains high, high means at the second decimal place, then the other options are you can do PET scan. So this is the way you go step by step. You don't jump onto your to any step without any evidence. So maybe I make myself clear, Komal.
Thank you, sir. Thank you.
Pleasure. So is there anything else that we can discuss? No? Right. Thank you very much. So we'll meet again tomorrow, 12 o'clock. Right. Thank you very much. Nafis.